I don't know if it's my... Please, can you go ahead, Karim?
Yes, I'm going to unmute myself. Okay. So it's my great pleasure to present my colleague, Maya Sidani, has been working in the UAE for many years. She is part of the MDT for the eating disorders program at the American Center for Psychiatry and Neurology in Dubai. And as we all do, she uses evidence-based models such as CBT-AR. She is also a psychotherapist who deals with different types of disorders, but since the COVID-19 pandemic, she has basically been focusing on eating disorders. She's a very frequent guest on television, radio shows. She likes to cover topics such as parenting, childhood development, and she's involved in community work and public awareness programs and workshops for schools, social organizations, mainly dedicated on raising awareness on eating disorders.
Okay, thank you, Karim. Thank you very much. So shall I start and I share my screen, okay? So first of all, are we all seeing my screen and the slide? Okay, great. So it's a great pleasure to be here and to present on a topic in our region, even though my presentation is about 1 month of the year, is particular about 1 month of the year, but the effect of this month can make or break the progress of our eating disorders patients. So I'm going to start with the outline. I would like to introduce first fasting in Ramadan. What are the general information about Ramadan, and how does it affect our patients? Why for some patients it's not recommended to fast in Ramadan, and why for others, or who are the patients who can fast? And what are the obstacles to abstaining from fasting when patients are not granted, or it's not recommended for them to fast? And at the end, I will cover what are the next steps and what to do, okay? So since I'm talking about navigating Ramadan, I would like to just show you that Ramadan was mentioned in the Holy Book of Quran in the Surah of Al-Baqarah. Okay, it is one of the main pillars of Islam. So fasting is one of the main pillars of Islam. There are 5 pillars in Islam, and fasting is one of them. It is Muslims are expected and requested to fast during Ramadan. It's the 9th month of the Islamic year. Fasting happens during daylight hours, so it consists of abstaining from food, drink, sexual activity, and smoking during those daylight hours. And then Muslims break their fast with an iftar, which is the meal that breaks their fast. It is a very important date and period of the Islamic calendar. It gathers 1/4 of the world's population because they observe this month from all over the world. And it's a great opportunity for Muslims to enhance their spiritual connection to God and exercise self-restraint. Fasting or Ramadan consists of 2 main meals, iftar or futur, which is the break of fast. It happens at sunset, starting sunset. And the other main meal is suhoor, which is the last meal before sunrise. And then Muslims are supposed to fast for around 17 to 19 hours during the day for around 30 days, 29 to 30 days, depending. So the duration of the fasting depends on different time zones, okay? So you can realize that the break of fast or iftar or futur, it would definitely involve exposure and consumption of very large amounts of food. So you can tell already that it could be fasting can easily be a medical and psychological challenge for the average Muslim. So what happens with our eating disorders patients in Ramadan? For our patients, fasting during Ramadan can be a real challenge, both physically and mentally, because it's an opportunity and they are at risk to have their eating disorder mindset reactivated and have a potential relapse in case it doesn't go really well. So the real intention of fasting in Ramadan is to allow the Muslim to understand and experience the pain and suffering of those less fortunate in the world, in order for the individual to acquire and gain some sense of gratitude and appreciation. That's the real intention of fasting in Ramadan. However, in reality, the eating disorder mindset can stray away the patient and start facilitating or triggering or urging the patient to engage in eating disorders behaviors, such as losing weight, cutting off some food, etc. So these are some quotes of patients who shared what was their experience in Ramadan. So this patient felt that it's an excuse for her to lose weight in Ramadan because the restriction is definitely justified. So even her mom was very observant of her diet, but Ramadan was a great opportunity for her to restrict even more without being noticed, because it's justified and even normalized. Everybody doesn't eat during daylight time, during the day in Ramadan. So there's nothing wrong with her behavior. Another patient also mentioned that even though the treatment team was against her fasting for her medical complications associated with her eating disorder, she still couldn't resist, and something inside her knew that she's using Ramadan as an excuse to lose more weight, and she was adamant to fast, and then at the end, she ended up at the hospital. So why not to fast for some patients with an eating disorder? The effects, the possible effects of fasting for patients with anorexia nervosa can be that it can become an obstacle to weight restoration for patients with anorexia nervosa. It can trigger weight loss in patients who have already restored their weight. And it can definitely reactivate their eating disorder mindset. For patients with bulimia nervosa and binge eating disorder, it can easily be an obstacle to regular eating, and it can trigger binge eating episodes during iftar and during the eating period. And of course, it can trigger reactivation of the eating disorder mindset. There are also two main fasting triggers that could be encountered or experienced by our patients. One is the heightened sense of fullness that Muslims experience after a long period.
Sorry, someone has to mute themselves. Someone has to mute themselves. Imran, can you mute, please? Imran, can you mute yourself? No. Can you unmute yourself, please?
Thanks, Erin. So Muslims or fasting people can experience a heightened sense of fullness after such a long time of fasting. So for those patients, they become very sensitive to this experience and this sensation, and this can trigger them to restrict more their food intake during iftar in order for them to avoid this heightened sense of fullness, and therefore they might eat less and less and therefore lose weight. The opposite trigger is the heightened sense of emptiness during daylight hours that also could trigger the eating disorder mindset for some patients who are still long for this sense of emptiness, and for the patients who have worked hard in their recovery and have let go of this sensation. So it gives them back this nostalgic feeling and could trigger reactivation of eating disorder mindset and therefore relapse. And all these habits, all these behaviors can be overlooked and unseen by the rest or their family members or their loved ones, because again, the behavior is justified or normalized during this period. So what could be the possible medical complications in anorexia nervosa with suppressed weight during fasting? In summary, the medical complications could be dehydration, low blood sugar, low blood pressure, electrolyte imbalance, and cardiac arrhythmia. For binge eating disorder and bulimia nervosa, the possible complication could be hyperglycemic flux from repetitive and recurrent episodes of overeating or binges, possibly causing insulin resistance and increasing the risk of onset of type 2 diabetes in case there is binge eating episodes during iftar. So before we move on, we need to know or to be aware that in Islam, it has been given permission to people who cannot fast to not fast. So these people can be the elderly, the ill, the pregnant, the breastfeeding, and of course the children. So this makes the question of is an eating disorder considered an illness or not, and the medical team should use their judgment to assess the severity of their medical and psychological condition. But also when making this decision, it's important for the treatment team also to assess the risks on both ends, mental and physical. Now, on a religious point of view, MIDA has contacted Dar al-Ifta, which is the high Islamic religious authority, and explained the possible medical consequences or complications for some patients with an eating disorder. And Dar al-Ifta, of course, confirmed that because of possible medical complications, patients with an eating disorder who are at risk of those complications are permitted to break their fasts during Ramadan and engage in other religious activities as a compensation. But however, we advise patients who are in doubt to seek advice from their religious authority after having had the medical team recommendation. So, on another hand, who can attempt fasting from all those patients? Fully recovered individuals suffering from binge eating disorder or bulimia nervosa can attempt fasting. Individuals suffering from binge eating disorder, bulimia nervosa, that are at the last stages of their treatment and who have been binge-free, compensatory behaviors-free for a significant amount of time can also attempt fasting in Ramadan. It is not indicated for individuals with a history of anorexia nervosa to attempt fasting. However, for those who insist, they can try. However, they should have been fully recovered with no relapse for at least 1 year. All these, provided that they fast with dietary guidance, provided that for all of them, fasting should be stopped immediately if they notice a relapse, weight loss, and or reactivation of eating disorder mindset. Now, when our patients want to attempt fasting, dietary recommendations with our dietitians are immediately provided and given. So the dietary recommendations in case fasting is permitted are the following. Meals should be regular between iftar and suhoor and with no gaps more than 3 hours in between. Meals should include all food groups. They have to plan ahead their meals in order for them to have a sense of control. And it should include desserts, treats, and all the possible avoided foods of the patient if they are still having avoided foods or working on avoided foods. So these are the dietary recommendations. Now, unfortunately, not all patients would abide or accept to abstain from fasting. We can encounter obstacles to abstaining from fasting. The main obstacles could be that the patients could feel very guilty and overwhelmed when not being able to fast during Ramadan. They could be susceptible and vulnerable to the social stigma linked to fasting, okay? And they could be vulnerable to the scrutiny and the questioning of their community members. There could be also, they could have misconception that eating disorders are not really a clear medical condition that warrants abstaining from fasting. So for some people, to abstain from fasting, you need to have a certain defined medical condition with medication to take during the day, not at night, after meals, etc. All these requirements for them only warrant abstaining from fasting. And uneducated members of the Muslim community don't believe that an eating disorder is a legitimate medical issue in order to grant breaking the fast. Now, the social stigma can also play a role in as an obstacle for our patients. So non-fasting Muslims can be labeled as bad Muslims. And the questioning that these patients could experience can be really triggering for them. And they can become, again, very susceptible to this kind of questioning and scrutiny. And they decide to not follow the recommendations, or it's really hard for them to follow the treatment team recommendations. So the type of questioning that are common is, have you tried fasting and failed? How is fasting today? This is a very common question during Ramadan. So everybody checks on each one's fasting routine and how is it going, and are you able to handle fasting? It's very triggering because it's very common. That's all what we speak about during that month. The comparison making, you know, the younger cousin was able to fast, how come you don't, you can't, etc. And again, questioning, why can't you fast, etc. Again, these questions can be very difficult for some patients. And this is also a quote from a patient who also mentioned that even though members of the communities had a good intention and were open to her eating disorder, still she received the question of, can't you just fast anyways? And this patient refused to fast during Ramadan, and she was aware of her condition and of her risk of relapse. Family members can be an obstacle. So because of the lack of awareness about eating disorders in our region, many families are unaware about and uneducated about the eating disorders. They don't know that such disorders exist. They don't know about the severity and the fatality of eating disorders. They could be not aware of their children's conditions, so not aware that their child is having or has an eating disorder, an active eating disorder, and or not consider it as a serious mental health condition. And because of that, patients with undiagnosed eating disorder, unrecognized eating disorder, will fast, and this will worsen their condition. And even with a diagnosed eating disorder, because of the lack of education, many families will oppose the recommendations of the treatment team against fasting and encourage their loved one to fast. Some patients are happy to not fast and accept it, but their family members will go against these recommendations. we have to remind our patients about the purpose of Ramadan. We need to remind them that fasting in Ramadan is not the only way or mean to have a stronger connection with God and with spirituality. Many patients believe that it's only by fasting that their sins can be forgiven. We have to remind them that it's not the only way, it's not the only purpose of Ramadan. Beside fasting, Ramadan's purpose is to connect more with God through praying more, through giving more, through reciting Quran more, through forgiving, through searching for inner peace. So what do we do? How do we move on from there? We have to educate. We have to educate medical doctors, healthcare professionals, and we have to remind healthcare professionals and our patients about the alternatives to fasting, and that I will mention later on. In the event that all fails, we have to educate our patients on how to fast in the safest way possible. And this is what we do. In the event that they still insist on fasting, we support them during this journey, and we give them the best dietary support and psychological support to minimize the risk of relapse. If it works, good for them. In the event it doesn't, they will realize that it wasn't a good idea this time. When families are on board, their role is very important, and they can act as reminders, supporters, and protectors. So they can remind their loved ones that eating disorders are the most deadly of all mental health disorders. So they do qualify as a medical condition that warrants abstinence from fasting. They can remind their loved ones that Ramadan is that God is not only looking for abstinence from bad characteristics, that in Ramadan, God is looking for abstinence from bad characteristics and bad habits. God is not only looking for fasting. So stopping bad habits such as a restriction, food restriction, can be really considered as a good deed. And again, this is the purpose of Ramadan. They can remind them of other acts of worship and practicing Ramadan values, and they can even do it with them, with their loved ones. So support them in these acts. Their role can be to protect and support their loved ones, so they can protect them from social pressure. They can stand up and face the others, the members of the community, and speak on their behalf and say something like, my daughter decided to not fast. She has taken a very courageous and wise decision this year and decided to not fast. They can support and encourage their loved ones to have meals during the daytime. They can also support them in having meals after iftar for those who are recovered and are trying to fast and attempting to fast. So have regular meals between iftar and suhoor. They can encourage their loved ones to be part of the iftar regardless if they're fasting or not, because iftar is a moment of unity and shared experience regardless of the fact that somebody is fasting or not, nationality, religion, or anything. So the patient will feel a sense of belonging and unity and participation during Ramadan. They can act as support, so they help and support their loved ones finding alternatives to fasting, so encouraging giving to charity, read Quran, feed others, and avoid triggering topics during this period. Now, there is also the option of postponed fasting in Islam. For the people who couldn't fast the whole month, okay, or some days of the month, who missed some days during the months of Ramadan, it is possible to make up for those days anytime, any day in the year. And this is a good option for our patients that they can postpone their fasting when they are fully recovered with the recommendation of their healthcare providers and with the supervision of their healthcare providers. So in summary and in conclusion, fasting is not the only way to explore and express one's faith during the holy months of Ramadan, and we have to repeat and reinforce this message to our patients. Patients can engage themselves in more spiritual worships like donating money, food. It's called fidya, it's called zakat, give charity, show small acts of kindness to people around you. You can feed another less fortunate fasting Muslim and provide iftars for poor, and it's very easy and very supported in the UAE. With a click of a button, you can provide as many meals. It's called iftars again, iftar meals to people. They can recite more Quran, read books about Islam, help and serve others, and pray more. And that's it.
Thank you so much, Maya.
You're welcome. Thank you.
I don't know if there is any question for Maya. I think I saw one for you, Maya. Give me 1 second. It's on the chat. Wait, it says, I believe there is usually a large social family, extended family meal in many cultures when people break their fast each day. In your experience, is that an issue as well for patients?
Let me please see if I understood the question.
Yeah, you can read
I
it on the
believe
chat if
I
you want to
can't
read it.
find it. For I believe there's usually a large social family extent in many cultures when people break their fast each year, okay, or each year. Is in your experience, is that an issue for our patients? Exposure to a big amount of food for patients with an active eating disorder can be triggering depending on their condition. So with binge eating disorders, with bulimia, definitely this type of exposure can be very triggering, okay? And this is why we provide dietary guidelines and psychological support in the event they want to attempt fasting in Ramadan. Because again, they see a big amount of food and they have been physiologically deprived for a long amount of hours and time. But this is again our role to teach them or to help them, to support them in getting the best experience without the relapse, through planning their meals, through having regular meals, through using their monitoring records, etc.
Thank you. Very interesting, Maya. Brilliant. Any other question for Maya? Okay, so thank you, Maya. So now we're gonna continue with our program, and our next conference is by Hala Abu Taha, and is treating ARFID with CBT-AR as a dietitian. So just give me 1 second. So I'm going to introduce Hala. It's my great honor and pleasure to introduce Hala. She's graduated in 2004 from Hashemite University, Jordan, with a Bachelor of Science in Clinical Nutrition and Dietetics. In 2006, she attended a program of diabetes education specialist, along with working as a clinical dietitian at the National Center of Diabetes and Endocrinology in Amman, Jordan. Hala earned her master's degree in psychological medicine from London Metropolitan University in August 2022. Hala has been working in UAE for several years, counseling individuals with eating disorders to implement the proper nutritional interventions within a specialized multidisciplinary team. She obtained her knowledge and confidence to work with eating disorder patients after getting supervision sessions with international leaders in the eating disorders world, such as Marcia Herring and Dr. Ricardo Dallagrave. Hala has completed her CREDO Web Center training on CBT-E for eating disorders, and she works with patients with BED, bulimia nervosa, anorexia nervosa, and ARFID confidently. Along with her one-on-one counseling, she has conducted multiple training sessions in the UAE and Lebanon to multidisciplinary teams. Hala also took part twice as a speaker in the International Conference for Eating Disorders conducted in Prague in June 2017 and in New York in 2019. In addition to her work with eating disorder patients, she has the passion and the knowledge to work with pediatrics with feeding problems, mainly ARFID applying CBT-AR protocol. So it is my great pleasure to introduce you, Hala, and please take the word.
Thank you. Can you hear me? Yes.
Yes.
So in general, if someone asked me 10 years ago that I'm going to be here, I'm going to presenting an eating disorder, I would question it, or 12 years ago. So working with Korean, learning by Dr. Ricardo taught me a lot, put me in the map. And I'm so proud.
Your presentation is no longer there.
Yeah, but I need to host disabled me. Can anyone?
1 second.
Okay, again, I'm disabled.
Corinne, it should be.
Okay, and there's a caption under Hala, so try to remove
yeah, I'm
the
trying
caption.
to. Yeah,
okay.
I'm trying, but I'm not being able still. Host disabled me.
No, you are.
I think you
now is
yeah.
okay. Yeah, and do you know how I remove the caption?
No, it's okay. Go ahead. It's fine.
Okay. Okay. So we'll start with treating ARFID with CBT-AR as a dietitian. In general, I just want to say that before, usually CBT-AR and CBT-E, as Karine said, before the COVID tsunami, I would say that we were not involved in general in holding the full treatment, but because of the load on our therapists and they're overwhelmed and the long waiting list, and after a full training of CBT-AR with Dr. Jennifer Thomas and lots of trainings and studying, we were able to conduct as a dietitians, me and my colleague Karina, conduct the full CBT-AR treatment. And fortunately, actually CBT-AR is I'm gonna talk in details about it now, but it's a protocol that was well designed and very clear, and it's proven that its efficiency with our patients. So as we all know that ARFID, it was introduced to DSM-5 in January 2014, defined as pattern of eating that is limited in varieties and volume and definitely associated with important medical and psychological consequences. Yeah, so to qualify the diagnosis of ARFID, patients should include one or more of the below, either significant weight loss or, for adolescents, failure to thrive, nutritional deficiencies, some cases dependence on tube feeding or formulas, energy dense formulas, or psychological impairments. In practice, this is what we see in our clinic. Usually patients with ARFID, they like McDonald's, specifically the chicken nuggets of McDonald's or the fries of McDonald's. They eat based on the texture, and very common that they eat based on a brand type, color, temperature, and in general, the features, they have very slow rate of eating. They eat smaller portions, less interested in familiar food, increased struggles around food, and it's a huge conflict at home, longer meal times, and increased, usually it perpetuates and develop more fear of new food. Harshman and colleagues in 2019 conducted a study showing the data from 52 patients with ARFID comparing to 52 healthy control. And participants with full or sub-threshold ARFID did not report any fruit or vegetable category in their top of the most commonly reported food categories. So that means also that patients, there's someone, mic is open. Hello? Yeah. Can you hear me?
Yes, Hala, we can.
Okay, yes. And also Dr. Thomas, in her presentations, usually she highlights that she found with her colleagues that usually patients from certain areas in the globe, they like different items. For example, she highlighted that people in Mexico, they more tend to fixate on tortillas. I noticed that in our country or in our region, they like more white rice. So but it needs to be more studied. However, they get fixated on specific food items with a specific criteria. Now, the role of dietitian, as I mentioned before, CBT-AR or ARFID is a psychological condition. So usually it's a psychological-led treatment. However, with experience and with learning more about psychology in my master's degree and with practice and learning from the online training with Dr. Jennifer, I was able to conduct the CBT-AR alone. So let's talk about the CBT-AR more. So CBT-AR, it's a flexible modular treatment for children, adolescents, and adults with ARFID that comprises around 20, which can be 30 sessions if patients are underweight. And it will be conducted over 4 stages. Stage number 1, psychoeducation and early change. Treatment. The second stage is treatment planning. Third is addressing maintaining mechanisms, and 4 is relapse prevention. And whoever works with CBTE, and since we are fully trained on CBTE, it's almost similar structure, and they have already gathered many tools and strategies from CBTE that we're going to talk about now. CBTE is delivered or offered in 2 formats. The first format is family supported format, which is if patients below 16 years old or underweight, and another format which is individual format, which is patients above or older than 16 years old and not underweight. However, we managed to do, even if patient underweight and above 16, it proven their efficiency if patient is below above 16 and still underweight. In general, we need to set targets and goals with the patient, because this helps us in achieving actually a lot in the patient. So in CBT-AR, the main treatment, or how does it work? It's the main treatment goals for, first of all, our patients, they're not going to be foodie. So we need to achieve or maintain a healthy weight. Secondly, we need to correct any nutritional deficiencies. Thirdly, we eat from each of the 5 food groups, which we're going to elaborate more later, and we will feel more comfortable eating in social situation, which is reduce the psychosocial impairments. We make it usually clear for patients that the treatment is not going to try to change their personality. They are who they are. They're not going to make them eat unusual food, because we all know that we all have our preference or unliked food, and we don't force feed whatever it costs us. The CBT-AR is designed to target 3 mechanisms. And as we said, it comes with 3 presentations. So the first one is the patients with lack of appetite, or which is lack of interest. And this study showed that appetite stimulating ghrelin is lower in ARFID compared to health controlled, while satiety promoting CCK is higher in youth with ARFID compared to health control. So they're born to be they're not interested in food. So we need to, CBT-AR is designed to tackle this mechanism. The second one is the fear of aversive consequences, which here I would really emphasize that a dietitian, most of the time, if the case is there is a OCD comorbidity, I don't do it. I usually refer to our therapist, whoever available, and they do it because I know sometimes my limit and I can't get over it. So the OCD or any comorbidity, I won't do it. The third one is the sensitivity, and with the sensitivity, most of the time, because I am privileged to work in Abu Dhabi, where everyone has a governmental insurance, so they have the chance to be assessed by occupational therapist, and then I can exclude any pathological sensory issues, which sometimes we can work in parallel with the occupational therapist. Stages of CBT-AR, as we said, the first one is the psychoeducation and early changes. It takes 2 to 4 sessions. Usually non-underweight patient takes 2 sessions and underweight patients 4 sessions. Treatment planning is 2 sessions. And then the third one is the addressing maintaining mechanisms, which is the core of tackling or addressing the maintaining mechanism, which can be the sensory sensitivity, fear of aversive food, aversive consequences, or lack of interest of food or eating. As any CBT, we need to do the relapse prevention, and usually it takes 2 sessions. To go more in detail, here, where this is taken from the amazing CBT-AR manual, which is available online. It's given me myself. I printed for all of my patients, and then we start work based on the flow of the manual. So as we discussed, the first one is learn about ARFID, which is similar to the CBTE. We start with lots intense of psychoeducation. We establish the either self or parent monitoring. We do regular eating, and of course, without personalized formulation, it's not going to be cognitive behavior therapy. So this is the amazing chart of the personalized formulation. It is at the very beginning, it was difficult for me as a dietitian to do it, but with time, now it's much easier to be taken from the patient collaboratively, engagement. This formulation can engage the patient to the max, because we all know that it's very challenging to engage the patient. At least in anorexia nervosa, patients would sometimes they really want to eat, but they cannot eat. Here, patients, they cannot eat. So this part of the treatment, which is the formulation, helped me as a dietitian a lot to keep the momentum with the patient and engage the patient. If the patient are underweight, and you'll see me now more excited because it's underweight, it's my category here. So normal weight can be determined by 2 things: the BMI, if adult and adolescent, and suppressed weight features. It's worth here to say that we have to focus on the weight loss or being underweight, because being underweight can actively impair the cognitive part in the patients, and then this can be an obstacle for the treatment. So we focus on detecting or knowing whether the patient is underweight or not. How are we going to know? Usually, if in adolescents, we take a history of the old growth charts if available. This is a patient for me. This was her height chart. And then we see here, it's a maintenance of her weight, although it's maintained. But as we all know, in adolescents, there is no number, it's more percentile. So because we have seen a maintenance of her weight, so that means it's a failure to grow, or it's a weight loss for us. The other one is, how are we going to increase the weight. We focus at the very beginning on psychoeducation about how to add 500 calories. Sometimes we don't use the word calories, but in general, it's how to add up 500 calories per day to achieve an average weight gain of 0.5 kilo per week. At the beginning, stage 1, it's very important to focus on weight regain, because without a proper weight regain, we cannot move to stage 2. So either by increasing portions of favorite or safe food, or we can add it on more frequent meals. We try sometimes to avoid using supplements, because we will find that patient will get stick to it, and it will be their safe zone somehow. But if it's necessary and we fail to gain weight normally with addition of a portion or frequent meals, we can use the meal replacement products. This is again, because I'm a dietitian, I like to have the food involved. So this is a graph for the high energy food, which we usually recommend at the very beginning, because it has a small volume with higher energy. So if you're a therapist and you work with a dietitian closer, so she will be knowing that at the very beginning, we can recommend a high energy food versus low energy food. Moving on to the second stage, which is, we call it continue for the patient, it's continue early changes and set big goals. For us, it's the treatment plan. And here is very important, because we're going to set our rules for the coming stage 3. So in the second stage, we usually work on more intense psychoeducation. What do we do? What do we want? We want to explain for the patients that what is the healthy plate, what is the aim of what are we doing, what the aim of our objective of the meals we are targeting, the deficiencies, which is very important to be explained, especially actually in the family-based version or format. So the mom usually will say, okay, we will make them hungry, they'll eat alone, or it's okay, my other son was like this and he managed to grow. So we explain in details, like if the avoided food, for example, milk and dairy products, calcium will be affected, and then ricket can be one of the side effects, meat and fish and eggs. So we try as much as possible to elaborate and give details about the food deficiencies. In the CBT-AR, they use a very nice detailed table, and you will find it also in the CBT-AR manual. And this explains the food items that we can, what is the deficiencies, the effect of the deficiency, where we can take it, and where the food source, and usually what is the side effect of it. And the third one, in stage 2, we work with the patient on we call it building blocks. And here we're collaboratively, therapist and the patient in the session, they go through a very big, nice, well-prepared table, and they assign or highlight together what are the food items that the patient is willing to start working with and to start the exposure with. So by now we're done with stage 2, and this is the time for stage 3. Since we have all the food that the patient is willing to start with, and we usually will ask the patient to start with the food that were last dropped during the progress of ARFID. So stage number 3 is face your fears. For us, is addressing the maintaining mechanisms, for sure. So we usually start with the most impairing mechanism. However, sometimes they will be 2 or 3 mechanisms together. We can find them overlapping with the lack of interest, sensory issues, or a trauma, history of trauma. So we're going to start with the most impairing mechanism. Mainly, we can start, usually it's recommended to start with the lack of interest for eating or food, or we can do the fear of aversive consequences. Typically, we keep the food sensitivity till the end. Of course, we have to keep consistent with the volume before variety, because if the patient has underweight, so we're going to be consistent with the volume before varieties, because already, even if the patient is not underweight, we don't want to cause the patient to be underweight. Reaching to this point, patient has already identified his food to avoid any nutritional deficiencies. So we start working on the module that we have chosen with the patient. In general, if we are going to tackle the sensory sensitivity module, we select the food to learn about that has 3 criteria. One, it increase the representation from the 5 food groups in the My Plate I showed you, that correct nutritional deficiencies and reduce the psychosocial impairment. And this is very nice working with kids because they will start immediately. They want to be blended in the society, in the birthday parties, and the going out and outings. So this will be a very nice incentive or motive to work with adolescents. Of course, as a psychoeducation about necessity of repeated exposure to enhance liking for novel food. We usually give them the example that you hear a song at the beginning and you don't like it, but then when you hear it again, you will like it. And for example, the video game, if you play the video game, this certain video game for the first time, you're not gonna like it, but with time, you will find yourself liking it. So we do highlight and has intense psychoeducation about the importance of repeating the exposure. We make sure that the patient will bring 5 novel food item to be tried or exposed in the session. And we make sure that they have to repeat it at home at least every day, 1 novel food from what already has been tried in the clinic or in the session. Mainly, therapists would help patient in this stage or this mechanism by a very nice handout explained in the CBT-AR, which called the 5 steps handout, where they going to focus on the expectation, where we're going to the color, smell, look, texture, and volume of the food item. Now, the fear of aversive consequences module, again, I'm not always capable and equipped to do this with the patient. Sometimes I do have to refer. Sometimes if the patient is mildly anxious, we can do it together. We provide psychoeducation on how avoidance increases anxiety, which I usually explain the 2 graphs where the anxiety avoiding is going to complete the anxiety, while the exposure might raise the anxiety at the begin, but we make sure that the graph will go down at the end. We create usually exposure hierarchy with the patient to include small steps leading up to food or eating related situation that led to initial avoidance. Continuous exposure until patient has completed the most distressing task on the hierarchy. In this module, we do usually introduce or explain the subjective unit of distress scale, which we have, or in the manual, they have a very nice sheet about we're scoring the distress from 0 to 100 before and after. So, and I love usually the look of with my patients when I see that the distress level was 100 before, and once they try it, they find that it's 50. So they will be surprised. So I always tell them that the first step is, if you're convinced that you can do it, it will make things definitely easier. And this can be every time I will go and have revise or revisit the formulation to prove for them that, oh, this is what we were discussing. Of course, we have to identify and reduce the safety behavior. We assign again to at home the food to be repeated as well, and we try at home also to give them the assignment to identify new items to add to their hierarchy. The lack of interest in food of eating module. This is my favorite actually one, because I love to do the interoceptive exposure with my patients. So we start with, again, psychoeducation about the strategies for eating enough and why we should eat enough, intense psychoeducation, and then we start in the session by interoceptive exposures. For example, for fullness, we drink, the therapists have to do it at the beginning. So we drink rapidly several glasses of water, and then we explain for them that yes, it's painful. Of course, you know how with the interoceptive, and then you'll find that the patient, you grabbed the full attention of the patient. Bloating, push belly out as much as possible, so the patient, you can see that you are feeling with them the bloating, nausea, spin the chairs till the end, and this is a very interactive strategy that will help the patient, knowing that you understand the problem. Basically, here where we add to the self-monitoring a part of the hunger and fullness, and in the CBT-AR manual there is a nice also handout explaining the scores or scale of hunger, fullness to hunger. In session, we start with practicing highly preferred food, and then we will start to go to the least preferred food. As any CBT plan, we have to prevent relapse, and this is here. I think that can be the easiest to prevent the relapse, since the patient are ready. We need to make sure that the patient ready to complete CBT-AR. If there is sensory sensitivity, that they have incorporated already several food in 5 food groups, willing to try new food, and fear of aversive consequences. They already eat most food that were previously not eaten, before the aversive action they were eaten, and decreased fear or anxiety around food. And in the lack of interest, they have already eaten on a regular schedule, and they increase their, as much as possible, enjoyment of eating. Psychosocial consequences, we need to make sure that there is no longer clinically impairing. Weight status, of course, we have to reach the normal weight and catching up normal growth. And nutritional status, there is no deficiencies, and all the deficiencies resolved. We need to co-create also a relapse prevention plan by make sure that we identify CBT-AR strategies to continue, of course, and we set goal for continued progress. Point to be discussed with the patients, usually ways that their eating has improved since the start of the treatment, possible future triggers for relapse, red flags that they might be starting to relapse, CBT-AR techniques that they will always use and need to use to continue or to try to on their own after treatment is completed, ways they would like to continue to change their eating post-treatment. I added only this for autism because today I received a very nice email from a school that specialized in autism in Abu Dhabi. I used to see one of their patients. She's 13 years old female that she had gastroenteritis, a normal gastroenteritis. She's very mild in the spectrum. And we did the CBT-AR with family version, and they were very appreciative for this approach because the patient now is eating everything family. I wouldn't say everything, every old safe food, and now she caught up with her normal growth, and she there's no more deficiencies. So that was one of the good examples for CBT-AR in a very mild patients in the spectrum. And thank you.
Thank you, Hala. Very, very interesting. I don't know if there are questions for Hala in the audience. So I'm seeing that people want the link to the manual in Spanish. I will put it on the chat in a moment. Any other question for Hala?
I do, but
Please.
I'm unable to start my video. The host has
Please,
stopped it.
Maya.
It's okay. Yeah, Hala, just listen to my voice. Yeah, Hala,
Yeah.
thank you very much for this beautiful presentation, as usual, Hala. Hala, from the top of your head, okay, I just would like to compare notes with you, but you are more expert in treating population with ARFID. What are the challenges that you are facing in the treatment?
Yeah, I'll be so honest, family dynamic.
Sorry, can I add? Can I
And
add?
I will go,
Hala,
no,
one-
Karin, wait,
No, a
wait.
question. I have a
Okay.
question. I'm adding a
Okay.
question. Am I allowed or not?
Yes, of
Thank
course
you.
you are.
As
I
a
thought the answer.
dietitian, what are your struggles as a dietitian? What are the challenges that you face as a dietitian treating ARFID specifically?
Yes, so one of them actually is like understanding the full underlying cause psychopathology. I did it at the very beginning. It was really very difficult for me to understand, but after a long and intense education courses with CBT-E, so I started to understand. But still, if I can only, I would say, treat a straightforward 1, 2, 3, 4 ARFID. If there is any small comorbidity, I won't be able. So one of my challenges is having comorbidities. This is one. Two, for my family cooperation, because ARFID is not like the abracadabra, it's the magic wand. It needs practice. The practice at home is more important than the exposure in the session. So if patient and the family, they will always say, we tried, but we couldn't. This is the sentence that I always keep. We tried, it didn't work. How come it works in the clinic? So usually the follow-up at home is a very big part and challenge at home, in my practice.
Excellent. Okay, we have another question. Mindful eating could be a part of this therapy?
Now, mindful eating can be promoted, yes, because anyway, especially that if the patient is distracted, they're not gonna process that they eat, and they have to, especially families, they have to reinitiate the process every time. So part of regular eating, when we establish regular eating, we usually promote that it will be as a family dining set, or at least in a dining set, not on rush, with mindfulness. Just that makes the coming food meals or food exposure easier, because the patients, especially adolescents, will be already used to such experience.
I think Ricardo has a comment, and also Carol.
Sure.
Dr. Ricardo.
No. I have no comment. Just a little doubt about the mindfulness, especially at the beginning of the treatment, because there are sensory problems, fear, many things that interfere to natural eating. So I think maybe to prevent relapse can be a strategy.
Yeah, but with underweight, of course, no, we don't usually promote that mindfulness, right? Especially with underweight.
And Carol?
Hi, Hala. Thank you for the beautiful presentation.
Thank you.
Hala, I wanted to ask you about the 5 types of food. I'm not practicing CBT-AR, but I assist sometimes. And why 5? And how easy for them is to bring 5? And would all of them accept to bring 5?
No, of course not. At the very beginning, usually we barely get 3, because they will lack, we don't know, we couldn't, we didn't think about something. So at the very beginning, they might bring 3 or 5, but it's progressive, and you will see the patient, once the patient trusted you and trusted the process, and will be engaged, and then they will start every time we go and revise again for the formulation, we revisit the formulation. Once they knew that they broke this fear and they were able to try, they will start by themselves encouraged to bring 5, 4, and sometimes, by the way, they will come and surprise us, and we do encourage and emphasize this, that they can at home, you didn't tell me to try this, but I tried that. So they will start working on family, like they tried the croissant, they tried the bread, they tried a cake, they tried biscotti. So this will be at the very beginning, 3 is challenging already, but later 5 will be very achievable.
And the 3 are to be eaten or just exposure?
Exposure. At the very beginning, we are good with a very small, tiny bite, or even sometimes they touch, they smell, they put it in their tongue at the very beginning. I don't like this personally, just to tell you that, I don't like small bites. However, if the patient is only accepting small bites, of course, I have to accept because it's collaborative working. So I usually not push, I wouldn't say push, I would say educate for just have a small bite, but not only lick it or on the top of the tongue. But at the beginning, yes, they will start touching or licking or smelling the 3 definitely out of 5.
And because of this challenge, do you think 20, 30 sessions are enough?
Yeah, you'll see. Yeah, actually, yes, with non-underweight patient, 20 sessions, perfect, more than enough. However, with underweight patients, sometimes I see resistance, especially that that it's, as we noticed, that sometimes ARFID can evolve to anorexia. So if they started having a bit of trait of body shape or overvaluation of weight or valuing being thin, sometimes this can be, we have to stop, we have to check for anorexia or overvaluation or scores, and then we go back for the CBT-AR if we couldn't find any overvaluation of weight and shape. And if we have, or if I highly suspect, by the way, and it happened recently, I will refer to the therapist. I'm not going to keep going with the case.
And I guess last thing is a kind of a comment, because I know you and I know how you practice that, but because you mentioned BMI as a target, but I guess as a dietitian, you do judge depending on the amount of food and not necessarily the BMI, right?
I do suppressed weight. I do suppressed weight features. I never do BMI, but BMI is because it's there in the books, and I cannot just be alone against BMI now, currently.
Yeah.
But I do
But
suppress.
because we're a different ethnicity, and the BMI here is completely different.
Even in the same ethnicity, race, the suppressed weight feature is different. We don't come even in the same race. So we do measure suppressed weight features. We don't do BMI. You're right. But again, the only way now to get documented, and it's there in the evaluation and assessment, is the BMI growth charts, and until now.
Thank you.
You're welcome.
Thank you, Hala. Very, very interesting.
Thank you.
Okay, so you